Here we are. So again, my name is Jake Mandell. I'm a musculoskeletal radiologist at the Brigham, and I'm going to talk about consistent reporting of lumbar spine MRI. So have I lost any of you yet? So hopefully you don't doze off, because I really like the interpretation of degenerative spine. I find it just like relaxing. You just get in the zone and look at the general things and go level by level, and it's like it's calm. And there's an approach to it, and I'm going to share my approach. Okay, so basically, when you're facing lumbar spine MRI, cause, effect, report. What do I mean by that? Cause is what's going on, discs, facets. And this really aggravates the fellows and residents that I work with when I first start with, because I really like to grade things. You don't have to say this is like a class 5B because I just made up class 5B, but you want to say enough that someone reading your report can imagine in their mind what's going on. So describe and grade causes. Describe and grade effects. And this is probably what might be frustrating to many of you as trainees or even attending, reading other people's reports, is the perceived inconsistency in how people grade things like spinal stenosis and foraminal stenosis. Someone might say mild, another person might say moderate, and even someone might say severe, and someone else says mild. So why? So I'm going to share with you a systematic approach to grade things, hopefully in a consistent way. And then report. So basically, my philosophy is that the impression should contain all the clinical information necessary to manage the patient, and use all the information available in the medical record. Where does the patient have pain, what type of pain, and so on. Okay. A couple pitfalls I just want to get out of the way. One is taking with you to the reading room an inherited kind of gestalt, meaning just based on intuition-based grading system without being aware of the established system. So for instance, I'll be reading with the resident and I'll say, I think it's mild, or I think it's moderate. And I say, why? It just looks like it. Well, are you familiar? And I try not to really hear into them too much, but are you familiar with any of the established classification systems for assessing spinal stenosis or foraminal stenosis? And in most cases, they're not. The other common pitfall is detecting hidden corners. So lumbar spine MRI, radiologists, I find for the most part, think about foraminal stenosis and spinal stenosis. Spine surgeons think about three things: foraminal stenosis, lateral recess stenosis, and spinal stenosis. And there can be clinically significant abnormalities in the lateral recess that you're not going to see unless you specifically look there. So that's a hidden corner for many radiologists, especially starting out reading lumbar spine MRI. And the second thing that radiologists often overlook is inflammatory changes of the facets. You only get one fluid-sensitive sequence on a routine lumbar spine MR, that's the sagittal stir. So you have to really utilize that to the maximum extent and scroll out laterally on both sides to see these changes. Another pitfall is skimping out on the impression. Please don't say degenerative changes as above, multi-level degenerative changes, FC report, something like that. Because again, the impression should contain all the information to manage the patients, and that type of thing doesn't. Okay, so causes: discs, bulge, extrusion, protrusion, sequestration, facets, ligamentum flavum thickening. Personally, I feel that ligamentum flavum thickening is probably overcalled by trainees. The ligamentum flavum is like the ventral part of the facet capsule. It's all contiguous with that. So, unless you're going to have big bulky facets, it would be quite unusual to have a thickened ligamentum flavum. So really only consider calling that if it's really markedly thickened. And then other things, but discs and facets are going to be the synovial cyst, meaning like a cyst related to the facet joint, or what I call blobs of mystery. Just something in the epidural space that's a blob that's not really connected to anything. The vast majority of these cases are going to be like extruded disc fragment, but sometimes you can't tell and you have to give contrast to see if it's some type of tumor. Okay, so I really like this classic article, the lumbar disc nomenclature version 2.0. Came out in 2014, and I use this to describe the disc morphology, disc bulge, disc protrusion, disc extrusion, things like that. So we'll just go over it quickly. This top bar.
You have more on the right. Applied floating meeting controls.
Oh, wow.
Yeah,
Okay, that's perfect.
That's very good.
but it's, I don't know,
Okay.
it's mirror image.
So here's a normal disc in
Still-
a diagram. The three terms to know are bulge, protrusion, extrusion. So it's just three terms. You know, that article might look fairly complicated, but I'm going to break it down for you. A disc bulge means 180-degree circumference of the disc is bulgy. That's why it's called a disc bulge. Protrusion, there's like a focal area, kind of like imagine an aneurysm, but the neck is not narrower than the dome. Extrusion is what we think of like a saccular aneurysm, where the neck is narrower than the dome. And it doesn't just have to be in the AP plane, like these diagrams say, but also craniocaudally, something extending craniocaudally, that could also be an extrusion. I would not use the term herniation. That's more of a layman's term. Technically, protrusion and extrusion are both herniations, but it's not specific. So either say protrusion or extrusion rather than saying the word herniation. Bulge, okay, let's focus on that. I like to say small, moderate, or large. That's as far as I go for classifying. You know, in this example, maybe this is a small one at L34. Maybe this is moderate, maybe it's large, maybe this is moderate, maybe this is large. There's no established classification for it that I know of to describe it, but do the best you can. I think that clearly these two and L23 and L45 are bigger than this one at L34. So again, use your words to make it so that someone interpreting your report will understand how to create the image of what's happening in their mind. Some terminology, this is not incorrect to say diffuse disc bulge, circumferential disc bulge. However, let's say in a very busy day, you read, I don't know, 20 MR lumbar spines. In each one, you're talking about 5 or 6 levels. And how many syllables does it take to say circumferential? Multiply those like 5 syllables by 6 levels by 20 MRIs, and that's one day of all those syllables. It's not necessary to say all that stuff because by definition, a disc bulge is diffuse or circumferential. All you have to say is disc bulge. So save yourself the syllables. It is okay to add modifiers if it's more eccentrically bulging to the right or the left or the foraminal region, things like that. So I would read a level like, for instance, L23, moderate size or large size, depending on what the axis look like. Moderate size disc bulge. Okay, done. Or if it shows that it's eccentric to one side, you can talk about that. So protrusion. Protrusions and extrusions get a little bit more complicated because there's a few different areas where they can occur. And this red area here would be central, or if it's just off central, it could be paracentral. This green area, subarticular. This kind of pinkish area, it's in the foramen, and this blue area, extraforaminal. So you should say where it is. And here's some examples. This is a central protrusion, maybe a large central protrusion. This one's paracentral to the right, this one's paracentral to the left. Now of note that like terminology document that I referenced that came out in 2014, it says to use right, left, central rather than right, left, paracentral. But personally, I just say paracentral because it's a little more clear that it's off of midline. Right, central, it almost sounds like a typo, like, well, is it right or is it central? So I just say right, paracentral, but either way is perfectly okay. Here's a subarticular one, and this is the lateral recess that's compressed. We'll talk more about this one later. And this one's foraminal. So you can see here on the sagittal, it's extending into the neuroforamen. We have an annular fissure, and we can see here it's going into the neuroforamen. And this one is probably more of a disc osteophyte complex. It's extraforaminal. So if this might do nothing, or it might irritate the exiting nerve root. So again, this is basic stuff. Let's pretend this level is L34. You don't know what level this is because it's just an accident image. Let's say it's L34. So what nerve is coming out here? This is the right L3 nerve. Excellent. And so these nerve roots in the lateral recess are going to be the descending L4. So maybe the extraforaminal either does nothing because everything's already passed, or maybe it irritates the exited or exiting L3. Okay, and then extrusion is like that saccular aneurysm. Again, it doesn't have to look like that in the axial. It can either go up or down. So here, there's cranial migration of this disc extrusion, but it's connected to the disc. The kind of next step would be a sequestration where the disc is totally separate. Where the disc fragment is totally separate. You know, as far as I know, like the extrusion doesn't have quite I mean, differentiation of location as protrusion, but you can still use the same terminology that there's a subarticular extrusion, things like that. Okay, now continuing on with the theme of causes, we talked about this. That wasn't so bad, was it? Now we'll talk about facets, and those are going to be the big two things that are going to cause problems. I think it's relatively uncommon for radiologists to classify facet arthropathy. You might say something like facet arthropathy, period, like it's there. But I really do think it's helpful to just put into three categories: a little, a medium, or a lot, mild, moderate, and severe. Let's talk about what you would use to like justify your choice, you know, when you're reading out with someone or when you're reading independently. So mild facet arthropathy, maybe there's small osteophytes, maybe tiny osteophytes. There might be some subchondral irregularity you can see kind of at this facet here. It's not smooth anymore. Maybe some tiny cysts, but there's no substantial mass effect. It would be quite unusual for mild facet arthropathy to like cause neural compression. Moderate facet arthropathy, just kind of an amplification of what we're seeing in mild. The osteophytes are bigger, there's more subchondral cysts, there's more subchondral irregularity. You might have some of the stuff here in bold. You might have a facet effusion, some periarticular edema or osseous edema, and that could tell you that it might be an active pain generator, an active facet arthropathy, or maybe related to instability. So flexion extension x-rays, if it's showing a difference, the facets can get irritated and show inflammatory changes. And then severe is the final step where there's large bulky osteophytes, large cysts, marked subchondral irregularity. And this would be thought to be perhaps the most symptomatic if it's a facet-mediated process, or most prone to like compressed nerves, even if the facet joint itself was asymptomatic. So here's just some examples. This one I would call mild. It's not normal. We have subchondral cysts, maybe a little bit of subchondral irregularity, but there's no spinal stenosis whatsoever. There's no ligamental flavin, there's no mass effects at all. This one moderate. In this case, we do have an effusion on the right side. We have more prominent subchondral irregularity and some osteophytes that are becoming more bulky. And then severe, we have thickening of the ligamentum flavum. Remember, I said ligamentum flavum is really associated with facet arthropathy. You would probably not see ligamentum flavum hypertrophy in isolation. So look at it together with your facets. Effusion, marked subchondral irregularity, big osteophytes. And then, especially if you see it looking like this on the axial, you're going along the sagittal stir to see if there's any edema, either in the bone, in the soft tissues, or effusion, even though we can see effusion. Yeah.
When you're seeing these effusions in the facet joints, when do you start calling it like a synovitis versus like just a pure effusion in that region?
Yeah, that's a great question. There would have to be a fairly substantial amount of fluid to see synovitis on a non-contrast MR, because you have to see some like kind of gunk in the effusion. This one, it's really too little to say if there is effusion or not. But facet effusions are associated with instability. So depending on the level of sophistication of your provider, they may need a little bit of guidance to get flexion extension x-rays. If it's coming from a spine surgeon, they would know. But yeah, the direct question, there would need to be a very big effusion, or perhaps a contrast enhanced study where you could see what the effusion looks like. Okay, so now let's talk about these perifacet inflammatory changes that are another kind of hidden corner for radiologists. So the three things are going to be facet effusion, osseous edema, and soft tissue edema. So here's another example of a facet effusion. Then you can see that there's some osseous edema, maybe even some soft tissue edema, but it's very hard to tell normal vessels in the back there from soft tissue edema. You really have to kind of compare to the other side. But most importantly, you have to scroll out on the sagittal stir images in order to see this. Here's another example. If you just looked on this axial thing, maybe someone would say moderate, maybe someone would say severe. Probably wouldn't it doesn't look crazy, right? But if you look here on the sagittal stir, you can see that there's soft tissue edema and osseous edema. No effusion in this case, but still, this should go in your impression, because depending on what they're presenting with, this could either be a sign of active facet arthropathy, could be treated with injection, could be a sign of instability. If you saw frank fluid, big effusion, maybe with synovitis with some junk in there. Maybe it's septic arthritis of the facets as well. That would be like, I probably wouldn't call septic arthritis in the setting of what looks like severe osteoarthritis of the facets unless there were some other signs. I have to scroll laterally. There. And then other stuff. So here's a synovial cyst associated with the right facet that's causing stenosis of the lateral recess, right? It's mild spinal stenosis. An extruded disc, facing the lateral recess. And this is, the blob of mystery. So you have this gray stuff in the epidural space kind of tracking along descending nerve roots. And this, playing odds, is going to be a sequestered disc. If you can't really tell what disc it came from, the discs will look fairly normal, then the next step would be to give contrast. And even if you think it's a sequestered disc, I think it's reasonable, in my opinion, to recommend this repeat with contrast. If it doesn't enhance, it's some type of disc. If it does enhance, maybe it's like some epidural. Okay, so effect. We talked about this, we talked about facets. And now, kind of, the area of most frustration is grading of all these things. So we'll talk about spinal stenosis, foraminal stenosis, lateral recess stenosis, nerve compression. Now, another word on terminology. Can I have does anyone say central canal stenosis? So, okay, good. There's nothing wrong with this. It's not like incorrect or anything. I think a lot at the Brigham, a lot of the neuroradiology people say central canal stenosis. And then the residents come to us and they say central canal stenosis. I'm like, what's the central canal? You mean that like little tiny bit of fluid in the middle of the cervical and thoracic cord that's obliterated? Like, if that was stenotic, they would get like hydrocephalus, wouldn't they? Anyway, so if you search PubMed for central canal stenosis, you get 713 results. And if you search for the more commonly accepted term of spinal stenosis, you get like almost 15,000 results. So I would recommend spinal stenosis. And then show of hands, who says foraminal stenosis? No one. One person. Two. Who says foraminal narrowing? Most. Okay. I don't think there's any right or wrong. I just like, you again, conciseness is your friend. So what's quicker? No spinal stenosis or foraminal narrowing, or no spinal or foraminal stenosis? So I prefer the second. And after a lot of emails, I convinced like our department to change their templates to no spinal or foraminal stenosis as the default negative. So, this is my preferred terminology. Foraminal narrowing, nothing wrong with it, but stenosis is, I think, a little more consistent. Why is one narrowing and one stenosis? Okay, so now I mentioned before that people should have a vague sense of what type of classification systems are out there. So then when you're reading with your attending and you say, oh, this is mild, and your attending says it's moderate, you could say, oh, well, according to Shizas in 2010, this is classified before. So you don't have to get that detailed, but basically, let's simplify this classification because I think it's a pretty good one. So first, we'll talk about a normal spinal canal. So just a review of some anatomy here. Of course, the disc is anteriorly, and you have posteriorly, you've got the facet, the lamina, and again, the ligamentum flavum. So normally you want to look for these features, that there's free distribution of nerve roots without crowding, that the nerve roots in the lateral recesses are, that you can clearly see that they're not contacting anything, that the anterior margin of the thecal sac is either flat or kind of concave like this. And then the posterior epidural fat, this is a T2 weighted image, so fat and CSF are going to be difficult to distinguish, but on the T1, the epidural fat will be bright and the CSF will be dark. That's preserved. At L5S1, you might not have that, of course, but otherwise you should be able to see that clearly. Okay, now the changes of mild spinal stenosis. There's some slight crowding of the nerve roots. In the lateral recesses, you can still see the traversing nerve roots, but they may be contact of something like either the disc in the front or the facet in the back. The anterior margin of the thecal sac may be flat or slightly convex. I don't say things like, there's some mild convexity of the anterior thecal sac. I would just say, oh, they're mild spinal stenosis, rather than putting all this words and not describing it as mild spinal stenosis. And the posterior epidural fat is still preserved. If I'm debating, is this mild spinal stenosis or not, I just scroll up and down a little bit. Does it open up when you go up? Does it open up when you go down? And if so, it's probably mild spinal stenosis. Here's another example of mild spinal stenosis. Okay, moderate spinal stenosis. This has quite a characteristic appearance on MRI. This image here, just burn that into your brains, where you have like the speckled appearance of the cauda equina intermixed with CSF. They're not really free-floating nerve roots anymore. It's kind of a homogeneous speckled appearance. And it's difficult to really figure out or differentiate the nerve roots in the lateral recesses. It's just kind of more blobs. Again, the anterior margin of the thecal sac may be flat, but it's often kind of convex, pushing in. You do still see the posterior epidural fat. Another example of moderate, kind of a speckled appearance of the CSF interspersed with the cauda equina nerve. And this would be a case of severe facet arthropathy as well. Okay, severe spinal stenosis is also fairly easy, in my opinion, because on the T2 weighted axial images, you don't see any CSF. It's really as simple as that. There's probably 2 grades of severe spinal stenosis. In the original paper by Shizas from 2010, they called it something extreme spinal stenosis. I don't use that term because it sounds kind of alarmist, and most of the time patients are walking around with this for a very long time. But let's talk about the features of each. So severe spinal stenosis, not the extreme version. There's complete effacement of CSF, and you cannot differentiate any nerve roots. It's just a dark blob on T2 weighted images. The anterior margin of the thecal sac is flat or convex. And to differentiate severe from the extreme, look at the posterior epidural fat. In this case, it's preserved. So this would be garden variety, severe spinal stenosis. And in this case, this is what Shizas calls extreme. I would say severe spinal stenosis with effacement of epidural fat. And so the imaging features are otherwise identical to the regular severe, but there's no epidural fat anymore. And this, in my mind, should make it into the impression. Severe spinal stenosis at L4-5 or whatever level with effacement of the epidural fat, because that tells the organ provider that it's really quite severe. So then, just as a summary, and I can distribute, like I've got a 2-page PDF that summarizes all this stuff. I'll send it to you guys. Got it. It's diagram. So again, normal, mild, moderate, and severe. The hallmark of mild is that just a little bit narrowed compared to the level above or below. The hallmark of moderate is the diffuse speckled appearance of the CSF, and the hallmark of severe is complete effacement of CSF. Extreme or very severe or severe with effacement of the epidural fat would mean there's no posterior epidural fat. Okay, so foraminal stenosis. I use this article from Lee from AJR 2010 kind of as the framework. And here's some images we'll go through to kind of simplify this one a little bit. Again, we're going to have mild, moderate, and severe. So some anatomy of the normal neural foramen. Here in this kind of sagittal schematic, if we blow up what the neural foramen looks like, we have the exiting nerve in the middle. The disc is anteriorly. Posteriorly, you have the facet and ligamentum flavum, and then you've got the normal neural foraminal fat surrounding the exiting nerve. Now, this is kind of a pitfall, especially for people starting to read out. Like, if the neural foramen is a little bit narrowed, kind of at the caudal aspect, but there's still fat all the way around the nerve, in my mind, that's still normal. I would not call that mild foraminal stenosis. So when do you call mild? You call mild, and this is based on Lee's work, if the foramen is touching on 2 sides. Excuse me, if the nerve is touching the walls of the foramen on 2 sides. So in this A example, it's touching anterior posterior. In the B example, it's touching the cranial caudal. Kind of our modification we did, because when we were doing a multi-reader study to like see concordance, people had a lot of trouble with this scenario where it's touching on 3 sides, but there's otherwise still preserved fat. So we would still categorize this as mild. And here's some examples: mild touching anterior posterior, mild touching cranial caudal. These are all T1 weighted sagittal images. Mild touching anterior posterior, mild touching on 3 sides, but still with preserved epidural fat. When we go to moderate, there's again at least 2 sides of contact, and the fat is partially effaced. So in mild, there's 2 sites of contact, but the fat is preserved. Moderate, 2 or more sites of contact, but the fat is effaced. So in this one, there's 3 sites, anterior, superior, posterior, but there's still some fat inferiorly and it's substantially effaced. Here, kind of a similar thing. And here, it's just anterior, posterior contact, but there's effacement of the epidural fat. There's less fat than we typically see. So moderate, moderate, moderate. And compared to mild, where it's touching on 2 sides, but there's still general preservation of epidural fat. And then severe is analogous to severe spinal stenosis. However, in severe spinal stenosis, you have effacement of CSF. In severe neuroforaminal stenosis, you have effacement of the epidural fat. So for instance, in this B example, is totally contacting. There's a kind of a caveat. If the nerve looks compressed, it's still severe stenosis, even if there's like a touch of epidural fat left in the neuroforamen. So in this one, the nerve is flattened, but there's a touch of epidural fat, it's still severe. In this one, it's flattened and there's complete effacement of the epidural fat, so severe.
I have a question.
Yeah.
How do you use this in the cervical spine, given that the sagittals look so much different on the lumbar?
That's a wonderful question. And a couple of people have asked me, and if you're interested in working on a project, we can do the same thing for the cervical spine, but this is just for lumbar spine.
Okay.
Yeah, cervical spine is a totally different beast that I think is much more challenging for everybody, including me. And then I was talking with the surgeons, like, yeah, hard for me too. Like, okay, glad it's not just me. The foramina on C-spine are very difficult because you have your T2s and your gradients typically, and they're each kind of showing different things. And then you have CT as well, where CT is excellent for the neuroforamina of the C-spine. C-spine, you're looking at the axials or like kind of sagittal obliques, where in the lumbar spine, you're looking just in the straight sagittal. So none of this applies directly to the cervical spine. Also, the cervical spine, you don't have cauda equina. It's just the cord. So everything here, just lumbar. But great question, thank you. Okay, so then as a summary, mild, touching on 2 planes or 3 planes, but with preservation of epidural fat. Moderate, touching on 2, 3, or 4 planes, but with effacement of epidural fat, partial effacement, and severe, either the nerve is compressed or completely. Okay, so now I'm going to talk about lateral recess stenosis. This is what I mentioned in the beginning as one of the hidden corners. So again, we'll talk about the schematic. You guys all know this, but it's still important to take another quick look at. So at the L4-5 level, depending on, let's say you have a protrusion. If you have a protrusion in the subarticular zone, that's going to get the descending or traversing, those words are synonymous, L5 nerve root. If you have a protrusion in the foraminal zone or some other cause of foraminal stenosis, that's going to get the exiting L4 nerve root. So you have exiting and traversing. Traversing equals descending. So this is a normal lateral recess. What's not normal about the center? We do have a small disc bulge with an annular figure here, but the descending nerve roots, you've got your dorsal and ventral nerve roots, sensory and motor nerve roots. These are normal. They're not touching anything. There's no stenosis here at all. When you have lateral recess stenosis, we're going to just divide it into 2 types for simplicity, a little or a lot. So mild or severe is, I think, enough. Basically, mild means that there's something touching the nerve roots. This can be like acutely painful. The imaging could be very unimpressive, and this is one of the causes, in my opinion, not based on any research we've done, just maybe a future project, that this is an area where the radiologists don't see things as well as the surgeons, because the surgeons have the patient in front of them, and the patient might have like a pure, let's say, right-sided radiculopathy. So we have to then look at that area. Even though there's nothing impressive going on, there is a small disc bulge and it's contacting the traversing right-sided nerve roots here. So this could be acutely painful. But there's no compression of the nerve roots. Now, this is area, of course, no one would miss a finding like this. There's large extrusion in the subarticular zone. That's compressing. It's completely effaced. You can't even see the nerve roots, the traversing nerve roots. So the first case, mild, that's probably the most subtle to call, and then severe effacement of the lateral recess.
What would you say about that spinal canal?
That's a great point. And I have another case that talks about that pitfall. mild. I probably wouldn't even mention it. I would probably just say there's like a large subarticular disc extrusion compressing the traversing. But I'm so glad you asked that because in a minute I have like a case that illustrates that exactly. Okay, so summer of lateral recess stenosis. Mild is abutment of the traversing nerve roots and severe is compression of the traversing nerve roots. Okay, so reporting DUs. Now, DUs looks like it's spelled wrong, but I checked 100 times and that's apparently how you spell it. It's not DOS, it is DUs. The apostrophe is not recommended apparently by various style guides. Okay, so do thoroughly describe what is happening. And as I mentioned before, the impression should include all clinically useful information to manage the patient. For instance, can the ordering provider make the decision of conservative care like PT, injection, surgery? If they're getting an injection, what level, what side, what approach, transforaminal, epidural? If they're doing a surgery, you know, what level, what type, just a decompression, do they need decompression infusion, and so on. That should all be in your report. Again, you're not going to recommend, I recommend an L4-5, you know, transforaminal fusion with interbody spacer. But with what you say, the surgeon should be able to make that decision for himself or herself. Okay, so here's some examples of what I think are kind of typical nice reports. Impression. Multi-level degenerative changes, most pronounced at L4-5, where a left eccentric disc bulge contributes to severe lateral recess stenosis and compresses the traversing left L5 nerve root, no spinal stenosis. So just seeing that, and you can get a sense, like this screams to me, I'm going to try like a left 4-5 transforaminal epidural steroid injection. If that doesn't work, we can maybe do a simple decompression. And you kind of have a management plan insinuated by what you're saying here. Here's another example of a different hypothetical case. Severe spinal stenosis at L4-5 with contributions from a large disc bulge and severe facet arthropathy, grade 1 anterolacesis and perifacet edema can be seen in instability. And so that tells the surgeon that, you know, there's severe spinal stenosis. An injection might be temporizing at best. If he's going to do or she's going to do a surgery, they're going to have to think about doing a fusion because there's perifacet edema and likely instability. So they're going to get flexion extension x-rays, maybe set up for an injection, but they're going to have a conversation with the patient that they'll probably need a fusion with hardware. So don'ts. Yeah, don'ts has an apostrophe because it's like do not, but it's you don't apostrophize plurals. So do not skimp on the impression. Do not be a robot. I mentioned don't skimp on the impression before. I don't need to belabor the point. Do not be a robot. Okay, so I asked ChatGPT for a graphic and it said, here's the do not be a robot sign. I did not ask for a futuristic cyberpunk style design. It just gave that to me and it do no be a robot. So I'll talk about that in a second. So again, don't do this, please. The red means don't do this. Or I've seen this, multi-level degenerative changes, you know, most severe at L4-5. And then like, I get this report back from the fellows. I don't remember reading a report with severe, I'll pull it up and there's like a small disc bulge at L4-5. And like, technically, everything else is normal, so I guess that's not wrong, but I'm thinking like, so please don't use the word severe unless it's severe. So most pronounced, or even better, in that example, which was a real case of a small disc bulge at L4-5, you can say just, you know, small disc bulge at L4-5 with annular fissure, no spinal or framal stenosis, I think would be more clear. Okay, don't be a robot. When to break out of the framework. This is an actual clinical case with the actual clinical impression pasted word for word, and I'm going to tell you what happened. So let's go through the case here. On this example, this same case, both audio images. So here we're at the level of L3-4, where there's a large paracentral / subarticular extrusion with caudal migration, effacing the left lateral recess. Maybe there's mild spinal stenosis. Here we're on the left foramen of L4-5. You know, there's no foraminal stenosis, maybe mild foraminal stenosis. There's no L3-4 foraminal stenosis, but you know, here's this at the L3-4, the L4 nerve is compressed. So here's the exiting L4 nerve at the L4-5 level, and it's high in signal intensity. Okay, but in terms of like the stenoses, maybe mild stenosis, maybe mild foraminal stenosis. If someone called this level normal, like that's okay, but if you zoom up, it's probably touching on two sides of mild. This is the actual impression. Left paracentral disc extrusion at L3-4 with mild spinal stenosis, no foraminal stenosis. All right, so like if you just read that, what image are you creating in your mind? Probably like that is mild, that is not a big deal. And so anyway, in our reading room, we have, it's actually an automatic door, like you press a button and it opens automatically. But if we had a regular door, it would have slammed open. So surgeon, actually the chief of orthopedic surgery, who is a very reasonable guy, but you know, he's a spine surgeon, so whatever it is. Anything of this impression, we spoke about that. Comes in, storms into our room, but it was anticlimactic because he's waiting for the automatic door to open. Then he walks in and says, I need to speak to the radiologist who read this case. So the patient's surgery is tomorrow and the insurance company denied it. So the report says mild, but the left L4 nerve is compressed and he has a foot drop. So, you know, don't be a robot. Everything in that report might have been like correct from the grading of the various stenoses and the description of the disc bulge. But if something is unusual or a nerve is compressed or the nerve is hyperintense in signal intensity, then you have to describe that. So let's revisit this and recreate this report, something that might be more able to, for someone not seeing the images, to recreate what's happening in their mind. So left paracentral disc extrusion at L3-4 faces left lateral recess and compresses the traversing left L4 nerve, which appears edematous. So now the insurance kind of robot person going in, oh, mild, 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 denied, is not going to be able to deny it anymore because we described that the nerve is compressed and edematous. Okay, so now a couple words on AI and lumbar spine imaging, because there's a lot of really interesting work here. And I think AI is going to really be our helpers in this area. So, again, I asked ChatGPT, can you make a picture of a robot analyzing a lumbar spine MR? Here is the image of a futuristic robot analyzing a lumbar spine MR in a high-tech medical lab. Let me know if you need any modifications. Well, let's just zoom up on the lumbar spine here. So this looks like some type of armless, legless beast. With 6 fingers and point there. There is disc degeneration at multiple levels, so I have to give it that. But it's just some very strange anatomy. So I asked to please make it anatomically correct, and it said, here's the updated image with a more realistic lumbar spine. and it's the same. But they added, hopefully, lumbar spine. So maybe there's some future progress that needs to be made, but I think that it'll get there. So imagine this, so all joking aside, this is what I think the end game of AI and MR spine interpretation is going to be: to create a perfect report, meaning containing all the necessary information to clinically manage the patient, integrating images with information in the electronic medical record with a high consistency and able to predict outcomes based on various interventions, taking into account current literature and opportunistic screening information on that scan, such as bone mineral density, muscle quality, sarcopenia, doing this all automatically and integrating it. So for instance, something like this, in the 72-year-old man with claudication, past medical history of MI, diabetes, all these things. There's severe spinal stenosis at L4-5, and then it puts in the opportunistic screening, and then it puts in what he's already tried by scraping the medical record, and then it says, oh, there's a 72% chance, I'm just making up these numbers, but predicting outcomes based on the intervention, integrating the imaging and the EMR and literature and opportunistic screening. I think we'll get there. There's no reason we can't. But we're still some way away. So let's just talk about where we are and where we're going to go. So specialized models versus generalized AI. Do you guys understand the difference between these for AI and imaging? So basically, specialized models means that someone takes the time to train a model. And there's been a lot of these made for the lumbar spine. So for instance, you can train a model to do the stuff we talked about. You can train it to grade the discs. You can train it to grade the degree of spinal stenosis, the degree of foraminal stenosis. But it's a lot of work to do this training. You have to have a lot of images, have them all labeled by experts, or take the data from reports. put it into a box with a lot of GPU horsepower, let it cook for several days, and you have your model, test your model. There's a lot of papers like this. Generalized AI are things like ChatGPT, Claude, like things like this, where universal, like large language models that know a lot about medical imaging, but they're not that good at image interpretation. So specialized models have been made for like segmenting the spine, various grading things like we spoke about, lateral recess, facet arthropathy, differentiating benign from metastatic fractures, things like this. These models have all been made public and reportedly with high reliability. Generative AI, there's a lot of literature on this as well, using ChatGPT mostly for things like clinical decision support, adhering to clinical guidelines, generating an impression from the findings, and possibly also predicting outcomes, simplifying reports for patient comprehension and so on. I just want to highlight one paper here, which is recently published, a meta-analysis for how accurate are these custom models for classifying lumbar spinal stenosis. And it turns out that they're good, but they're not yet good enough. So the sensitivity and specificity of 0.84 and 0.87, and it was the conclusion of the authors that none of them are reliable and practical enough to apply in real clinical practice. Do you have any AI that you use here clinically? Yeah. We actually don't really yet at the Brigham. There's a lot of research in the area. And so how are they being used, like for kind of anything spine related?
No.
Cervical fracture.
Okay,
PEs.
okay. And so it like alerts you that there might be a PE. And you find that helpful? So
Depends on what
Rib fractures, yes.
rib fractures.
brains.
Yeah,
It has value. It's not, it's considering how many years we've had it, the progression it's had is very minimal.
yeah. So that's kind of where I think the state we're at for the lumbar spine. There's a lot of work in the area, but there's nothing that's comprehensive. I think it's going to be a combination of these custom models fed into some type of generative model to like synthesize everything. I think in the future, we will be able to get to that kind of hypothetical thing, but yeah.
I mean, I think it's your chair, but has said to me like 7 years ago that they were like 12 months away from being able to have automated reporting on lumbar spine MRs. And obviously that has not happened.
Yeah,
And I'm just curious if you, and this report is sort of addressing what I would be concerned about. Is it even getting close enough where somebody could be presented with an editable report that even if it's way off, still gives you a good starting place?
I think so, yeah. But again, in that like edge case, like the don't be a robot example.
Right.
Like it might give you kind of a garbage report of saying like, mild this, mild that, that would be correct, but not clinically helpful in that situation.
But you're not even using anything operational yet to
That's
even-
correct, we use nothing.
Yeah.
Yeah, but I think that we will get there, and I think it would be helpful. The problem is that the training data is all based on reports, which are very helter-skelter.
Yeah.
And rather than having a more consistent kind of ground truth fed into the models.
I think we'll get there too. I just think it's a question of whether it's in my lifetime or not. So,
I think it will be. I think, but it's still gonna be like kind of our assistant.
Yeah.
Rather than press a button and it's gonna generate a report. Yeah. So I think that's our future. We're not there yet. Again, it still puts the same darn spine image, like, like serpent thing. So in summary, that's the end. That's all I have to say. We spoke about causes. Discs and facets are going to be the main thing. The take-home point is be sure to look sagittally on the stir sequence to see the edema around the facets and report it if it's there. We spoke about the effect, spinal stenosis, foraminal stenosis, lateral recess stenosis. Don't forget to evaluate the lateral recesses and then put everything into a framework so you can justify. I think it's mild foraminal stenosis because it's touching on two sides, things like that. And then we spoke about the report where the impression should contain all the information necessary to manage the patient. And don't be a robot. AI is coming. There's a lot of progress, still a long ways off from a universal system to create a unified, helpful report. That's it. Thank you so much.
Anybody have any questions?
This isn't specific to lumbar spines, but when you talk about creating ground truth to train or create AI models, if you aren't going to use, and I understand what you mean by the inconsistency by using reports to generate and train those AI models, but then how do you have a standardized approach to create ground truth in order to then train and create appropriate and predictive AI models?
Well, probably like the most time consuming way would be to have like several expert readers, establish the ground truth. Then you can look at their concordance, and if they're highly concordant, then that gives further like justification that's high quality ground truth. But that's very time consuming. So the advantage of reports is you can have like 20,000 reports like done in a year. At least at MGB, I think they do about 20,000 lumbar spine MRs in a year across the whole giant network. And then you can use some type of AI or natural language processing to take those reports and then classify the levels, then get the images, give it to a machine that can be all automated. But again, it's relatively low quality ground truth, but with high numbers compared to a high quality ground truth requiring very time consuming manual annotation of images.
Thank you.
Great, thanks.
Do you want to just check on Zoom, make sure there's no questions there? Not that I expect there is, but there is Q&A at the bottom. I don't know if this.
How do you deal with epidural lipomatosis? Oh, that's a great question.
It's live.
You would like to answer this question?
Just do it.
Okay, I'm done. Yeah, so that's a great point. I didn't mention that in the contributors. I should put that in other. So next time I give this talk, I'm going to revise it to add epidural lipomatosis in the other category, but I would put it in as other. So the same thing like the facet cyst or the blob of mystery. If there's something else that just fits into the framework, I would say that there's epidural lipomatosis contributing to moderate spinal stenosis, or just add that to the factors. The same thing like if there's a facet cyst contributing to effacement of the lateral recess. Thank you for that question.
And then it looks like there's one other question. It says, is making the distinction between extrusion and protrusion have clinical implications?
So I don't know about the difference between extrusion and protrusion. I think that from what the surgeons tell me, most of what I've learned here has been from like, we have a weekly spine conference with a group of surgeons, including orthopedic and neurosurgeons, and that's kind of how we made this classification. We all kind of did it together. What they tell me is that the best thing to have, kind of counterintuitive perhaps, is a sequestration, because that's going to be the most likely to resorb on its own. I don't know if I'm just conjecturing here, if protrusion, since it's kind of on the way to a sequestration, is going to be more likely to resorb rather than a protrusion. But again, I don't know. That's a good question. And does this framework apply to CT and MR? It's really just on MR, because the way it was defined with how the nerve roots and the CSF and the epidural fat and the nerve are interacting can really best be seen on MR. If you really window things and it's a high quality CT and you're really looking, you can probably read a CT the same way like you read an MR. And you could, if a patient can't get an MR, it's very reasonable to try to read the CT with the same level of detail and consistency, but you would then just have to make accommodations because you might not be able to see all of the relationships as clearly in an MR. I might say things like, there is at least moderate spinal stenosis, just put in little kind of modifier words. You can't see exactly what I need to see.
Thank you.
All right, thanks, Jake.
Thanks again.